Welcome back to our series of seminars on epilepsy. Let's do a quick recap of some of the key points from session 2. Any person may develop a seizure given certain circumstances. It's always important to find any underlying treatable cause, such as metabolic, infections, trauma, and toxic. When a seizure occurs due to an underlying medical cause, and the medical problem is well treated and resolves, it will likely not lead to unprovoked seizures in the future, which is epilepsy. If the medical problem was severe and prolonged, or was not treated properly, it can result in lasting brain damage and scarring. Any brain scarring or abnormal brain tissue can act as a focus for abnormal seizure activity in the future, even after the medical problem is resolved. A good clinical history, physical exam, investigations are all vital to helping us find an underlying cause. The better our investigation methods, the more likely we can find a cause. So what happens in a resource-limited setting where testing is not as available? We rely primarily on a good clinical history and physical exam. With or without investigations, a good clinical history and assessment can give us a lot of information to figure out the type of seizure and choose appropriate medications. Here we have a snapshot of some of the key points we've learned so far. As you know, a seizure is the event, and epilepsy is the disease associated with spontaneously recurring seizures. Epilepsy can be diagnosed when a person has at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure with the probability of further seizures occurring, or diagnosis of an epilepsy syndrome. As we discussed in session 2, neurons or nerve cells are the building blocks of the nervous system. They transmit signals from the brain to the rest of the body. In the brain, there are 2 main neurotransmitters: glutamate, which is the excitatory neurotransmitter, and GABA, which is the inhibitory neurotransmitter. A delicate balance between these two maintains normal function in our brain. Excessive excitation of the brain can lead to seizure and epilepsy. This brings us to session 3, clinical features of epilepsy. Objectives. At the end of session 3, you will be able to list the 4 components of a seizure, describe the clinical features of these 4 components, describe the characteristics of the different seizures commonly seen in our clinical practice, and apply what you have learned to clinical scenarios. Components of a seizure. As you see on the left, there are 4 components of a seizure. First is the prodromal phase, which can occur for a few hours or even days before the actual seizure. Second is the aura, which typically precedes the seizure by a few seconds or minutes. Third is the seizure itself, which typically can last a few seconds to several minutes. And finally is the post-ictal or post-seizure phase. This phase may be absent, brief, lasting a few minutes, and in some patients even hours or days. These four phases usually occur on a timeline. The important thing to note is that not all patients will have all four phases, and not all types of seizures will present with all four phases. A thorough clinical history about the presence or absence of these four and the nature of these phases can aid in diagnosis and management. Before we go on to describe the four phases that you see on the left, I'd like to quickly review seizure triggers. We talked about this briefly in session 2. Not all patients will have specific triggers, and even if they do, they may not be able to identify them. So educating patients about these possible triggers will make them more aware and might help them avoid these triggers and even avoid seizures or decrease the frequency of seizures. The most common trigger is missed or late medication, and therefore educating patients about the importance of medication adherence is very, very important. Other commonly seen triggers are flashing lights, hyperventilation, physical stress, emotional stress or anxiety, or other extreme emotional states, lack of sleep and fatigue, poor diet or missed meals, hormonal changes such as in pregnancy and menstruation, certain smells or sounds or sensations of touch can trigger seizures in some patients. High fever or other illnesses can precipitate a seizure. Alcohol or drug use, dehydration or overhydration, and certain drug interactions of either prescribed or over-the-counter medications can trigger seizures. Prodromal phase. This can begin a few hours or even a few days before the seizure happens. Not everyone has a prodromal phase, and it should not be confused with aura, which happens immediately before the seizure. A prodromal phase is more of a change in the baseline status of the patient, where they can develop symptoms such as headache, irritability, insomnia, bad temper, depression, or increased activity. Aura. An aura precedes the seizure by a few seconds or minutes. It is basically the beginning of the seizure event. Again, not all patients will have it. It depends on the type of seizure. The aura signals the focal onset of the seizure. The symptoms depend on the location of this focus in the brain. The feelings of aura are often vague and indescribable. it can cause the patient to feel very anxious and fearful. At this point of the seizure, the patient has not lost consciousness yet. So typically, they can remember that they had aura, although they may not be able to describe it clearly. Some of the examples of symptoms patients experience during aura include dreamlike experiences of déjà vu, of feeling of detachment from reality or confusion, sudden emotions such as panic, fear, joy, sadness, or anger, certain unpleasant smells, sudden taste sensations, which may be bitter, salty, sour, metallic taste, or sweet, unusual visual experiences like flashing, blurred vision, and even hallucinations, auditory sensations like hearing voices or ringing or buzzing sounds, strange epigastric sensations, and even nausea or vomiting, lightheadedness, headaches, and sometimes numbness or tingling in a certain part of the body. Seizure. Characteristics of a seizure. Although the most commonly seen seizure in clinical practice is the generalized tonic-clonic seizure, we will learn today that there are various clinical presentations of seizures. Age of onset of seizures, duration of the seizure, frequency of seizure, time of day or night that the seizure occurs and its relation to sleep, presence of any triggers or prodromal phase, presence or absence of aura, presence or absence of postictal phase. All of this information will help us make a diagnosis, choose the right medication, and also help educate the patient and their caregivers to take appropriate precautions. We will learn more about why these are important later on in this presentation, as well as learn how to get this information during history taking in next week's session. Postictal phase. This phase can occur after the seizure ends. It may be absent, brief, may last a few minutes, hours, or even days in some patients. Usually following a seizure, the patient can have deep sleep and may wake up with headache, tiredness, irritability, vomiting, confusion, muscle aches, or ataxia. Some patients can have a transient paralysis of a part of the body where one part of the body can be weak, and this can last for a few hours or even days. Knowing this can be helpful for both providers and patients so as to reassure them. A patient can also have altered speech or aphasia if the dominant hemisphere of the brain, which is usually the left hemisphere, is involved. And some patients can have altered behavior, emotional outbursts, and even violent or aggressive behavior. So knowing all of this information, if we think back on certain cases that we've seen, where patients have recurrent seizures every few days on the inpatient unit, and between the seizures, they are aggressive and have behavioral problems. Rather than trying to treat it, we have to understand that it could be part of this post-ictal syndrome. And the primary thing to do would be to treat the seizure so we can prevent the post-ictal phase altogether. Let's review the International League Against Epilepsy's 2017 classification of seizure types. It's divided into focal onset, generalized onset, and unknown onset. Focal onset, as you can see on the lower left image, involves only a specific part of the brain. And this can be without loss of consciousness, aware, or with change in consciousness or impaired awareness. And they can present with motor symptoms or non-motor symptoms. Next, generalized onset always has loss of consciousness, and they can present again as motor, most commonly the generalized tonic-clonic that we have all seen, and non-motor, which is usually absence seizures. I'd like to emphasize the difference between a focal and generalized seizure. If you look at the picture on the bottom right, the brain on the left shows no abnormal activity. So this is a normal brain or the prodromal phase. In the middle, you see abnormal activity that is contained to a localized area of the brain. At this time, a patient can develop symptoms of aura and then a focal seizure. Aura only occurs with a focal seizure and not with a generalized seizure. If a focal seizure converts to a generalized seizure, if the abnormal activity spreads from one part of the brain to the whole brain, it's called a secondary generalized seizure. For example, if a patient suddenly has loss of consciousness with only the right hand jerking for about 30 seconds, and suddenly the rest of the body goes into a generalized tonic-clonic seizure. This is the clinical presentation of a focal seizure that converts to a generalized seizure. Therefore, secondary generalized seizure. Some patients from the onset will present with a generalized tonic-clonic seizure. This is called a primary generalized seizure. It may not always be easy to differentiate this in clinical practice, but a good and focused clinical history may be able to help you differentiate. The reason we need to differentiate it is the drug of choice, the anti-epileptic medication of choice, may differ depending on the diagnosis. We will learn more about pharmacological treatment of epilepsy in an upcoming session, and this will start to make more sense as we proceed. This is an expanded version of the classification of seizure types. It shows some of the common motor and non-motor presentations, which we will go on to describe. On this slide, you see the different motor presentations of seizures. First, we have the purely tonic type, where the patient falls down, usually letting out an epileptic cry or scream. Their body becomes stiff, the legs extended, the arms flexed, and they can have urinary incontinence. Next, you have the purely clonic type with alternate contraction and relaxation of the upper and lower limbs, as well as the rest of the body, which presents as the typical jerky movements that you see in a seizure. They can have frothing of saliva at the mouth and blinking of the eyes. The most common presentation, the most widely recognized presentation of a seizure is the generalized tonic-clonic, which is a combination of a tonic and clonic presentation. It usually starts with the tonic phase and then proceeds to a clonic phase. Then you can have an atonic presentation where the person has sudden loss of muscle tone and muscle control. Their head may droop and they can slump or fall down. We don't usually recognize this as a seizure, but what we're going to start learning is seizures have various presentations, including something like an atonic presentation. Next, you have a myoclonic presentation. Myoclonic muscle spasms of the limbs or trunk or head can occur as violent jerking movements or even twitches. Epileptic spasms that you see last on the list typically occur in infants. They're usually called infantile spasms in children under the age of 1. And the importance of differentiating these different types is the medication of choice can be different. For example, in an epileptic spasm or infantile spasm, the medication of choice is not an anti-epileptic medication at all, but rather a steroid. Now, we're going to review the 4 main classifications, starting with focal onset aware. This was previously called simple partial seizure. The patient does not lose consciousness. The patient can remember the event, but the experience may be so strange that they may not be able to express what exactly happened. What symptoms they experience is dependent on the location of the affected area of the brain. Different patients can have different types of presentations. They can have motor symptoms like twitching of the face or of the hand or abnormal movements of other muscles in the body. Sensory presentation where they can have a tingling sensation, numbness on certain part of the body, cold or heat sensations, or hearing, visual, and smelling sensations. Some patients can have autonomic presentations, where they have a strange sensation in their epigastrium, in the stomach, flushing or palpitations or sweating. Some patients can also have cognitive, behavioral, or emotional symptoms, where they have altered mood, memory, thoughts, and perception, sometimes even hallucinations. Because the patient is awake and the presentation can be so varied, these focal onset aware seizures usually are not recognized as seizures until they turn into generalized seizures. Next, we have focal onset with impaired awareness. Here, the patient does not have complete loss of consciousness, and they may be slightly aware of what is going on, but cannot respond or alter their behavior during the seizure event. Aura is typically present, and the patient experiences severe anxiety and fear when they have aura. Sometimes the seizures can occur with hallucinations or psychomotor symptoms, such as automatisms and automatic movements. For example, pulling at their clothes, chewing movement, lip smacking, or repeated aimless movements with their hands or head. In some patients, these automatisms can be very complex, and the patient is able to perform difficult tasks or even travel somewhere, but later not remember having done such a thing. He suddenly comes to again and finds himself in a completely different place. During such an automatism, the patient may become aggressive and violent when restrained. Although rare, it's important to be aware of such presentations, especially as they overlap with psychiatric symptoms. This is why previously these seizures were called psychomotor seizures. Localization is often to the temporal lobe of the brain, which is why they were previously called temporal lobe epilepsy. The patient usually has complete amnesia of the event, and they have a slow recovery with a post-ictal state where they can remain confused. Next, we have generalized onset, non-motor presentation, which are absence seizures. Absence seizures are short periods of loss of consciousness or loss of responsiveness. They last only a few seconds, usually not more than 30 seconds. They have no or minimal motor manifestations. They usually present as a blank staring spell with brief upward rotation of the eyes and sudden interruption of the activity that the person is doing. They are unresponsive when spoken to, and suddenly the seizure is over and they continue with the activity that they were previously doing. It typically affects children. They can happen in clusters multiple times a day. Because the symptoms are so subtle, they are not easily recognized. They have a very typical presentation on EEG, which can be used for diagnosis. They are usually provoked by hyperventilation. Absence seizures were previously called petit mal, but we no longer use the term because it is very nonspecific. A child with absence seizures may have only absence seizures or can also present with other types of seizures. The picture of the little boy on the left shows an example of an absence seizure with a staring spell. As you can see, it can be quite subtle and not easily recognized by a child's parents or teachers as being a seizure. This is often confused with a child just daydreaming in class or being distracted. The picture on the right shows a young boy reading a book. Suddenly, with the onset of the absence seizure, he drops his book into his lap and has a blank stare on his face. Once the seizure is over, he will pick up his book and continue to read as if nothing has happened. He will have no recollection of the seizure event. Finally, we have generalized onset, motor presentation. We previously went over the different types of motor presentations, but as you know, the most common type of seizure we see is the generalized tonic-clonic type. This was previously called the grand mal seizure. Again, we no longer use this term. A generalized seizure will not have aura. Only a focal seizure will have aura. A focal seizure that turns into a generalized seizure will have aura in the beginning. In a generalized tonic-clonic seizure, the patient has loss of consciousness, falls down, sometimes letting out a scream. As previously discussed, it starts with a tonic phase and continues to the clonic phase, as you see in the picture, followed by a postictal state with no memory of the seizure event. I'd like to add a short note on status epilepticus. A seizure that lasts for 30 minutes or longer, or seizures that are so frequent that recovery between the seizures does not occur, is called status epilepticus. This can be any type of seizure, not just a generalized tonic-clonic seizure. A prolonged absence seizure can also result in status epilepticus. Status epilepticus is a medical emergency. As a mental health team, it is not within our role to manage status epilepticus. However, it is important that we are able to recognize when it has occurred and refer the patient for appropriate management. It is within our role to ensure that the patient is safe and to immediately transfer to a setting with IV medications. If left untreated, it can result in severe brain injury morbidity, and even death. Status epilepticus can occur as a first-time presentation of seizure or in the setting where a patient has suddenly stopped anti-epileptic medication, which results in a severe withdrawal seizure. If a person presents for the first time with status epilepticus, there's a high risk of an underlying brain tumor or other structural focus in the brain and must be fully investigated. Stopping the seizure and simply starting on an anti-epileptic medication is not enough. Further investigations will be needed. Status epilepticus can be classified into the convulsive status with motor presentation or non-convulsive or stupor status, which can be absence or psychomotor presentation. So if we see a patient with prolonged behavioral problems, not responding to, say, Haldol, we have to consider if it could be due to epileptic activity and take appropriate steps. Treatment of status epilepticus includes IV loading dose with phenytoin or phenobarbital, as well as IV infusion of diazepam if needed. This must be managed by the medical team. The patient may also need other supportive measures such as oxygen, IV fluids, etc. At this point in the presentation, you may be wondering, why do we need to differentiate the types of seizures? Is it going to affect our management? And the answer is yes. It's not always easy to differentiate them clinically, or even with EEG and CT brain, we may not be able to differentiate it because the presentation of seizures can be quite complex. But it can definitely make it easier if we know the different types. You know the right questions to ask when you take history from the patient. It helps us recognize a seizure even when it is not the obvious or typical type of seizure. You get better at recognizing the overlap between seizure and psychiatric symptoms. Some of the mood changes, behavioral changes, cognitive changes that we typically think of as just psychiatric symptoms can sometimes be a presentation of a more subtle seizure. Although we use only 4 anti-epileptic medications commonly in practice, even between these 4, we can choose one over the other depending on the type of seizure. Like I said, we will learn more about pharmacological management of epilepsy in a future session, and this will become more clear. You can educate the patient about their illness better. You can let them know what to expect. You can also educate family and caregivers. This reduces stigma and anxiety and equips the patient and caregivers to cope with the illness better. As I mentioned, you can start appropriate treatment, choose the right medication for the type of seizure. Also, it helps us know our own limitations and know when to refer the patient for higher level of care when needed. Understanding a patient's symptoms in detail helps improve overall success of treatment and recovery, and ultimately improve quality of life of patient. Now, let's do a clinical scenario. A 13-year-old boy was referred to the district hospital mental health clinic from the health center. He came to the clinic with his mother. His mother reported that the boy has had 2 crises in the last month, each lasting 2 to 3 minutes. His third seizure happened yesterday evening. What will you do next? Do you have more questions that you want to ask the mother? Or is this information enough for you to make a diagnosis of epilepsy and start, for example, Depakine? A full assessment and treatment plan can significantly affect recovery of the patient. Sometimes, with just the information we have on the previous slide, a child may be diagnosed with epilepsy and started on any available anti-epileptic medication or the first anti-epileptic medication that occurs to the provider. However, it will be important to ask some follow-up questions to figure out what type of seizure the child has had and build a timeline and see how the illness has affected the child and the family in order to build an appropriate treatment plan. For example, how was the child prior to the first seizure, before 1 month ago? How was his general well-being? Get more detail about the first seizure. Was there a prodromal phase? Any change in the child's behavior in the hours or days leading up to the seizure? Does the child or mother recall the presence of aura, which is any unusual experiences right before the seizure happened? How long did the seizure occur for? Can the mother describe the seizure? What happened to the child's eyes and head and limbs? Which part of the body was moving or not moving? What associated symptoms did he have? Did he have urinary incontinence? Stool incontinence? What happened after the seizure? Did he have any post-ictal confusion, headache, irritability, or other changes? How long did this last for? The key is to build a timeline around the seizure as well as of the child's entire life. Next, ask similar questions about the second seizure and the third seizure. What happened in the periods between the seizures? How is it affecting the child's general well-being, school performance, etc.? You will also need to do a physical exam, check vitals, do lab investigations, send for an EEG, consider ordering a CT scan of the brain. And once you have made a diagnosis, you can make an appropriate choice of anti-epileptic medication and create a biopsychosocial holistic treatment plan. Let's go back to the clinical scenario. So you go back and ask more questions. Mother says the child was well prior to the first seizure. For 2 days leading up to the first seizure, the boy was not sleeping well. Then suddenly, one day, during dinner, he fell down from his chair. His eyes rolled up and his body was stiff. Then his arms and legs started jerking for 2 minutes or so. Then it all stopped and he was very drowsy for half an hour. During this time, he had passed urine without realizing. After an hour or so, he was back to normal. The second seizure happened when he was at school. The child was sent home from school after he fell down and started jerking and passed urine. He was drowsy and confused for a while, but mother did not know further details as she was not present when the event occurred. The third time the seizure happened, yesterday, was similar to the first time, at home when he was watching TV. Given this information, what is your diagnosis and why? It is clear that the child has had a generalized tonic-clonic seizure, possibility of a prodromal phase with poor sleep. No aura was described. Child initially had a tonic phase with uprolled eyes and stiffness of the body, which proceeded to the clonic phase with jerking of his arms and legs and urinary incontinence. He also had a post-ictal phase of drowsiness and confusion. Given this diagnosis, we can then go ahead and make a treatment plan. Clinical scenario 2. An 8-year-old girl was referred to the mental health clinic for behavioral problems and poor performance in school. For the last year or so, she had been getting into trouble in school. According to her teacher, the patient was, quote unquote, often daydreaming and not paying attention in class. Her grades in class were dropping, and because she was often scolded by the teacher, patient started acting out. At home, her parents noticed she was often staring into space, but nothing else unusual. What will you do? There may be many explanations for this patient's presentation. However, it's important for us to know that it could be absence seizures. The parents or teachers may not volunteer specific information as they may not know that it is relevant or important. So it is important for us as providers to ask specific questions when taking history to elicit those answers. Ask them to describe in detail what is happening with the patient. This helps us decide whether or not we start an anti-epileptic medication in a child. Using an anti-epileptic drug where it is not needed can be harmful. However, leaving absence seizures untreated or not recognizing that they're seizures can cause the child to continue to perform poorly in school and end up affecting her entire life. Once we have made a diagnosis, the drug of choice for absence seizures is valproate. It's important to know this because medications such as phenytoin and phenobarbital, although effective against generalized tonic-clonic seizures, are not effective against absence seizures. So it's important to know that the drug of choice is valproate, but it's also important to know which of the anti-epileptic medications we should not be using. This brings us to the end of session 3. Murakoze Chane, and please feel free to share your feedback and questions.